I'm Chris Gilligan, and I'm the division chief for the Division of Pain Medicine at Brigham and Women's Hospital. So a wide array of patients can benefit from seeing a pain medicine specialist. Ones that come to mind immediately are patients with back or neck pain, including herniated discs and spinal stenosis. Patients who have back and neck pain in the setting of having had a prior surgery, perhaps. Patients who have cancer-related pain can frequently benefit. There's a wide array of both medications and procedures that we use to try to improve that situation. For the treatment of patients with spine pain, neck and back pain, we're very involved in trying to help patients get better, and if it's appropriate and if it's possible, help patients to get better and help them to avoid a surgery. And then patients with conditions that are really characterized by the pain. So headache conditions, trigeminal neuralgia is one, patients with chronic abdominal pain or chronic joint pain in a setting where there isn't a simple surgery that's going to resolve that. Coming to see our group and see, can we come up with something that would be helpful, either through the multidisciplinary biofeedback, relaxation techniques, through use of medications, typically with an emphasis on non-opioid medications, or through some of the different procedures that we do. So chronic pain is inherently extremely stressful. So there's really, to get good outcomes, we have to be able to offer good treatments to try to address the physical element of the pain. And also, we're having a severe chronic pain condition is very, very stressful. We also have to have the resources to address that stress and the anxiety, the depression that all of that can contribute to. I became interested in pain medicine because I saw that for patients, really treating severe pain conditions is one of the very most important reasons that a patient seeks care, comes to see a doctor, comes to the hospital, is severe pain. Two examples that I would think of where practicing pain medicine can be very rewarding. One would be a patient who I treated who had pancreatic cancer and had severe, unrelenting abdominal pain. And we were able to do a procedure where we used alcohol to deaden the nerves that innervate that area of the abdomen. And when I checked that evening on the patient to say, well, have you gotten pain relief from the procedure? He looked at me and he said, it's like there was a light switch and you turned off the light switch, you turned off the pain. That was incredibly rewarding to me. Another instance was a patient who had very, very severe pain following several spine surgeries. And it really was quite a tough situation, but in the end we were able to get him very close to pain-free and with excellent function, and it was really a question of seeing a human being to a certain extent get his life back. Once we get involved in a patient's care, we're involved really until we've either helped the patient to have a substantial or one hopes complete improvement, or until if we reach a point where really we can't offer anything helpful, perhaps we would be stopping. But once we're involved in a patient's care, we're that patient's doctor. And so we're there to try to help that person get better, both in terms of their pain control and their function. We're very clear on what our goal is for every patient that walks in the center. And we don't achieve our goal every time, but I'll tell you, we know what we're aiming for every time. We want every patient who walks in to get excellent, appropriate, high quality, safe care